Hey everyone, welcome back. I'm Dr. Samantha, the maternity mentor, and we're here for another one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. This is your time to answer any questions that you have for me live, as well as my time to answer questions that you've submitted onto the channel. So anybody who has any questions, please feel free to put them into the chat. Remember, we're also on Facebook, Instagram, and Twitter for additional content. If any of you are there and hearing me, I'm going to go ahead and restart because my timer looks like I had a tech issue. So I apologize if this is a duplicate. Hold on, we're just checking something. Hi, I'm Dr. Samantha, the maternity mentor. We're here on a Monday at 9 p.m. Eastern Standard Time for another one of our live Q&A sessions. This is our chance to answer any questions that you have for me live, so please feel free to put those into the chat, as well as answer any questions that you may have submitted onto the channel this week. Remember, we're also on Facebook, Instagram, and Twitter for additional content. We will link those into the description of the video after it's posted. And for those of you who stay with me until the end, you will get a sneak next week, tomorrow's video. Please remember to like and subscribe to the channel. Subscribing to the channel really helps me out as a content creator. So I really appreciate that. So remember, if you have any questions, please feel free to put them into the chat. And I'm going to go ahead and I'm going to get started with some of your questions. So I want to start off with a question that we had on breastfeeding while pregnant. And it said, I'm 1 month pregnant and my son is 10 months old. Is it okay to keep breastfeeding? So this is a great question to start us off. Many of you know I am a board certified lactation consultant. I've been a lactation consultant for almost 13 years. And I have worked with a lot of women in this circumstance where they do find out they're pregnant and they are still breastfeeding a baby. So it used to be thought that you couldn't breastfeed while you're pregnant, and that's really changing. If there are no health concerns, you are able to still breastfeed. However, a lot of times breastfeeding isn't successful for a variety of reasons. So for starters, our bodies are primed to go ahead and start making colostrum around the 6th month of pregnancy. And what colostrum is that first milk that's very thick like honey. And when you're already breastfeeding and you have an established milk supply, what sometimes can happen is you can actually have your milk supply turn from that thick turn from a full milk supply back into the thick colostrum. That is usually noticeable because what'll happen is the baby that's been breastfeeding will start to get fussy. They may not pee and poop as much. They may start to lose weight, or they may stop breastfeeding altogether. So this is a really common reason why people actually stop breastfeeding or are told they can't breastfeed, because this phenomena of going from a full milk supply to colostrum can happen. Now, that does not happen for every woman. Every single woman is different. Secondary is the whole idea of, could breastfeeding cause preterm labor? So what happens with breastfeeding is there are a couple hormones involved. There's prolactin, which is the milk-making hormone. This is the hormone that makes quantities of milk. Unfortunately, prolactin is highest at night between 1 a.m. and 4 a.m., maybe 12 a.m. and 4 a.m. And so this is why when you're first breastfeeding a newborn, we tell you need to feed the baby at night, even though you're tired and the baby may sleep through. The more you feed in the middle of the night, which is of course when you want to sleep, the more likely you are to make more milk, because that prolactin is highest during that time and you're stimulating it. Now, the second hormone is oxytocin. Oxytocin is the milk ejection hormone. So that's the one that says milk come out of the breast, okay? This is also the hormone that's responsible for contractions when you're in labor and the contractions that you will have when you have an orgasm. So when women have an orgasm and they get that nice contraction feeling in their belly, that's caused by oxytocin. So when you are breastfeeding a baby while you are pregnant, it is possible for you to start to get contractions. And of course, contractions can lead to you going into preterm labor, which is one of the biggest concerns that people have and why a lot of women are told not to breastfeed. So one of the things you need to examine is what are your risks for preterm labor? If you've had a baby that was preterm before, if you know you have an incompetent cervix, if you're on your feet all the time and they think that could add to stress, if this is, any number of reasons. So at 1 month pregnant, you may or may not have seen your healthcare provider yet, but you need to go ahead and contact your OBGYN and ask them for further guidance as to whether your pregnancy is safe enough for you to go ahead and to breastfeed while pregnant. So that's kind of where we're at with that. For those of you who are joining, please feel free to put your questions into the chat. So, secondary to that, now we have a bottle feeding question, right? So, I'm a new mom. I have a 1.5-month-old baby. Every time she is sleepy and about to sleep, she cries a lot, like a lot of crying. I did a lot of things to soothe her and nothing is working. I don't know what to do anymore. Is it normal when she cries a lot before every sleep? I also don't think it's colic. So this was on the bottle feeding video they have, I think, because she was concerned about her feeding technique. So there's a lot of reasons why babies may cry before they go to sleep. What I will tell you is 6 weeks is the start of the season of colic, okay? So colic is a phenomena that we see between 6 weeks and like 10 to 12 weeks, maybe a little bit longer than that. It's oftentimes blamed on formula. And I will tell you that, and any breastfeeding mom will tell you that breastfed babies also get colic. A lot of times we see that it is blamed on cow's milk, for example, or allergies related to milk. That can be the case sometimes. But what you'll find is even all these families that cross off everything, they get a new formula, they fix all the stuff, they still will have periods of irritability, especially towards the end of the night. And there's a lot of research going on that's showing that this actually may be your baby getting a headache from sensory overload. So if you think about it, around 6 weeks of age, your baby starts to become more aware. They're awake a lot more often, and they're really starting to interact with the world. And at that time, once they start to interact, everything is new. Every sight, sound, smell, touch, everything. And imagine if 100% of your waking hours was full of all new sensory information. Eventually, that would be a lot for anybody's brain to handle, and it could cause you to get like a headache or irritable. So it makes sense that towards the end of our days, our babies are a lot more irritable and colicky, and we think that that's part of what's going on. Now, is it normal for your baby to constantly be crying before they go to sleep? I would say not. There's a lot of complex things going on before a baby goes to sleep. So it really depends on a lot of factors. But the first thing that I think of is actually GERD, gastrointestinal reflux disease. Okay. And so what I would tell you is that's basically really bad reflux and heartburn. And what it can definitely be worse when you lay your baby flat, which is what you should do. Babies should be laid flat on their back to sleep because of SIDS. So if your baby has reflux, that can be particularly hard for the baby. And it may be that there's a lot of acid coming up, and that's why the baby is reacting that way. So I would suggest that you head to the pediatrician and explain what's going on so they can check the baby out further. So anybody who has any questions, please feel free to put them into the chat. I had a question. I had a couple things come up about anxiety. The first one is a little bit disturbing. So for anybody who is pregnant, this might be a trigger alert for you. So you may want to just be okay or prepared or muted or whatever. And so the first question was, do other women think about the chance of dying in labor? I think about that. So I think this is a really good way to open up the topic of anxiety. Many women will have a lot of anxiety, even if they've had a baby before. Labor and delivery is a very overwhelming environment. There's a lot going on. There's a lot of anticipation, and there's a lot of unknown. Despite all of our technology and everything that we can scan and test and all this other stuff, there's still a lot of things that we don't know when we go into a birth. And so that's kind of scary. Then there's all sorts of new procedures and new tests and new terminology that you're just not used to. And so things that we don't know about are scary. Well, one of the things I would tell you guys to do, and I would encourage you guys to do, is try to check out as many of my videos that kind of prep you for labor and delivery as you can. For example, one of the things I did was what to expect when you, I think it's when you get checked in to the hospital. I have one on what to expect during an induction, what to expect after a vaginal delivery, what to expect after a C-section, what to expect in the operating room. These were all designed to give you kind of very focused information about each one of these pieces of the process. And there's a lot of pieces. And it's very important. As I move along in the channel, I try to very much give more and more of these little tiny pieces of information that I can in a concise way so that people can make informed decisions. A lot of people aren't sure what's what. And I would encourage you to ask the questions. Ask every single question you can to anybody who is a legitimate healthcare provider or a legitimate source. But people do think about dying. There's a lot of scary stuff. There's a hemorrhage, for example, which I have videos on. We hear about that all the time. We hear about the effects of preeclampsia. So women do think about that. Now, what can you do? One of the things that's the most evidence-based treatment for anxiety during a pregnancy is therapy. Therapy is amazing. It is designed to help you talk through and process different types of fears, as well as develop strategies for managing those fears, okay? You are not alone, and it is really important to get that stuff addressed. I will tell you, as working in psychiatry, I do work with a lot of women who are pregnant, who are like dealing with anxiety and depression and stuff like that. And what I'll tell you is a lot of women don't take any medication. They really don't want to. So I'll manage that with some supplements, maybe certain strategies like electrolytes or exercise. Definitely, I try to get them in with therapy. But oftentimes towards the end of their pregnancies, when I'm seeing them for our medication management appointments, and it's medication management, I say this because at any point in time, I may offer medication and a mom still may refuse, which is her right. We end up talking about the other pieces. You know, what is it going to feel like to get an epidural? What is it going to feel? What are they going to ask you about your baby when the baby comes out? Like, what medications, like the vitamin K shot or the hepatitis B shot? I answer questions about different types of inductions and what is it going to look like. That's one of the things I do because that is a psychiatric tool. Like education is a tool for anxiety. It helps to manage it. Very homeopathic and very easy. And women need this because they are scared. So that is a real thing. And I encourage you to seek out a therapist and try to work with a therapist to help manage that. And if it's really bad, you can even try medication. Now, the other thing I'll tell you guys that you can do to help manage your anxiety, and especially that kind of really big fear during the labor and delivery process, is hypnobirthing. So I think hypnobirthing is fabulous. One of the girls that I used to work with at the hospital, she has her own hypnobirthing course, and I've talked to her extensively about it, and she's so passionate about it. I've talked to some of my patients who've used hypnobirthing through a variety of different means, and hypnobirthing is just amazing. So hypnobirthing is a form of relaxation that's kind of teaching you how to relax the mind and to focus the mind to help manage pain. we think about it as a strategy for a woman who wants to have a natural delivery, meaning a delivery without pain medication. But what a lot of people will tell you is that hypnobirthing can be used for so much more. Hypnobirthing can be used for somebody who's planning on getting an epidural. It can be used for somebody who's having a C-section, because the other strategies involved in hypnobirthing can help you to manage your fears. They can focus your mind and allow you to embrace the experience of the birth of your child and be more present in that, even when things aren't going exactly according to plan. So I would tell you that you should definitely look into hypnobirthing, because I think it's a fabulous tool to be used when you have a lot of anxiety. Hi, Lucine. I had my cervix measured via an abdominal ultrasound, and it measured 1.8 centimeters. You're 26 weeks. Had it checked again, and it measured 3.9 centimeters. Is it possible that the mistake range is that big, and the second one can't the second one be wrong? So this is a fantastic question for multiple reasons. So let's start with, for anybody who is not 100% sure of some of the stuff that she's talking about. Uterus, cervix, okay? Cervix should be long, thick, and closed. This is the perfect representation of a cervix. When you guys are not pregnant, if you stick your fingers into your vagina, you can actually feel your own cervix, and it feels kind of like this, to be very honest. Now, when your cervix dilates, it goes like this, right? So it actually starts to do this, and I'll explain that. This is perfectly representative of a closed cervix, and this little slit is where your mucus plug is. So when it starts to dilate, the mucus plug comes out, okay? Now, uterus, cervix. When you have contractions, what happens with the contractions is the contractions start to do this to your cervix, okay? So slowly it goes up like this. You see how I go from thick to thin? That is called effacement. That is where we start to thin out the cervix using contractions, and then the contractions pull that cervix apart, and that's dilation, okay? So a short cervix, 1.8 centimeters. When she's talking 1.8 or 3.9, she's referring to the length of the cervix. That's it. It's just a measurement. So is it possible? Absolutely. It is absolutely possible that the measurement changed, because ultrasound is not always accurate. I would ask, and please feel free to put it into the chat, was the second one possibly a transvaginal? So for those of you guys who don't know, abdominal ultrasound, that's on the outside of your belly, there is also a transvaginal ultrasound. So this is where there's a long wand, and it looks kind of like, I don't know, a big stick, and they put like a sterile cover over it, okay, which kind of looks like a glove or a condom or something like that. They put a little bit of jelly on it, and then they insert it into the vagina. And once in the vagina, they can see a lot of images a lot more clearly. Depending on what's going on, sometimes they'll do a transvaginal, sometimes they won't. Transvaginal ultrasounds are oftentimes a lot more accurate than abdominal ultrasounds for a lot of different things. The second one was also abdominal. The first one was at 24 weeks. The second was at 26 weeks. Okay. So it is, and that's fine. That's actually better, because it's kind of like an apples to apples. Your cervix did not lengthen. Okay. So it is possible the second one is a mistake. It is possible that the first one was a mistake. And unfortunately, there's no way to know without a third one. Ultrasound is dependent on a whole bunch of factors, including the technician being able to get the right images, and the radiologist, the person reading the result, to read it properly. So I'm going to ask you another question, Lucine. Was this read, were either one of those measurements read by a maternal fetal medicine physician and or a perinatologist? For those of you guys who don't know, a maternal fetal medicine physician / perinatologist are the high risk doctors. These are the guys that take care of you, guys and girls, who take care of you when you're having a high-risk pregnancy. This can include thyroid issues, diabetes, hypertension, preterm labor, multiple babies, all this different stuff. So they are the true experts in a lot of things. They read ultrasounds all the time. So it's possible, depending on who read it, that that could also be one of the issues. I suspect that the 3.9 is more likely than the 1.8. So when it comes to these measurements, when you guys have ever seen the ultrasound, they on your belly, they have to go under and they slide over and they do all this stuff because they're trying to get through tissues. And ultrasound is actually like sound waves, and the sound waves bounce off of different like structures and stuff. So you have to get it just right in order to get the image that you want. If you've got a seasoned technician who does like OB ultrasounds every 5 seconds, these guys can get the exact right images very easily. But if you have somebody who just graduated from school and has done like 3 pregnant women, they may not. And that's part of the issue also. When I was working in the hospital on the high-risk antepartum floor, that was for pregnant women who were having complications and required, they needed to be in the hospital for medical reasons. We did a lot of ultrasounds. Every day we were doing ultrasounds, and pretty much every patient got an ultrasound every single day. When we did that, our maternal fetal medicine physician only allowed like 4 ultrasound techs to work on our floor. She would not let anybody else work on the floor because she personally trained them over and over and over again to make sure their images were spot on. So these guys came in and they knew exactly what we needed, and they always got really good stuff. No, it was an ultrasound read by the facility where I had the ultrasound done. My OB said if the second one comes out also 1.8, he will recommend me to do the vaginal at a high risk practitioner. Yeah. So I suspect that the first one was done wrong. I just think that, and it does happen. Maybe they just didn't get the right look. If you have an anterior placenta, for you guys who don't know, the placenta, there's a couple different positions. Anterior, which is front towards your belly button, and posterior, which is back towards your spine. When you have an anterior placenta, it is harder to get a lot of stuff. Harder to get the baby's heart rate, harder to get ultrasounds, like harder to feel the baby kick, all sorts of stuff. I would suspect that they're going with the second ultrasound, and I would also suspect that he would want to recheck that in again in another 2 weeks. I'm hoping that's what he would do so that you can just confirm for sure, Lucine. Please feel free to add any questions into there if you have any others. Going back into I actually think I'm going to kind of build off of some of this. So we had a couple questions on subchorionic hemorrhages this week, and it kind of builds off the whole short cervix. So the reason why they're checking Lucine and her short cervix, and they're making sure that she is being checked and like they're looking at it, is because that could cause, she could be on the road to like an incompetent cervix. Now for Lucine, they probably would not offer a cerclage, and I have a video on cerclage, but that's where we basically stitch the cervix. At 26 weeks pregnant, you're 26 weeks, the baby's doing pretty good as far as a preemie goes. They'll probably give you the steroid shots to help mature the baby's lungs, and they'll kind of wait and see how things go. So subchorionic hemorrhages are something we see a lot with bleeding, okay, which is another kind of preterm labor type of thing. So I had a couple questions. So I'm 27 weeks pregnant and I'm experiencing bleeding. At 25 weeks and 6 days, I started bleeding and went to see my OBGYN. An ultrasound was conducted and it showed that my baby was okay, except for the external part of the cervix, which was open. I was not experiencing any pain. I was admitted to the hospital for observation and discharged the following day. Progesterone, folic acid, and Silopam, I don't know what Silopam is, were administered. I've been experiencing light spotting. I could also feel my baby's movements. Could this be a subchorionic hemorrhage? The second question, ma'am, on my 5-week ultrasound, a few tiny subchorionic collections were seen superior to the gestational sac. Is it dangerous? Please reply. I'm 28 years old. So in order to answer the first question, I'm going to start with the second question. So subchorionic hemorrhage. So we have a placenta. This is our placenta. On this side, you have a whole bunch of blood vessels. Oh, you're so welcome, Lucine. So we have a whole bunch of blood vessels on this side. This is our uterine wall. And we attach those together and we get the system for feeding our baby. It sends nutrients and oxygen and blood to the baby, and it takes away toxins and all that other garbage the baby doesn't need. So this is our system. Now, these are all open blood vessels. And if you've ever gotten a bruise where you kind of hit your arm and you get that collection of blood underneath the skin, well, that's just a whole bunch of broken blood vessels. So those blood vessels break, and then you get a whole pooling of blood underneath the skin, and you'll get an area that turns black and blue. That's all the blood, right? Now, that black and blue area may start out like this, but over time, that resolves, it heals. And as it heals, that black and blue gets smaller and smaller and smaller. That's what usually happens with the subchorionic hemorrhage. With subchorionic hemorrhages, they usually get smaller and smaller and smaller and disappear. And so sometimes, though, if the subchorionic hemorrhage is on the edge of your placenta, you might get some leaking that comes out in the form of spotting, and then you'll see some bleeding because of that. So subchorionic hemorrhages are usually not too much of a big deal. For the person who asked about having multiple subchorionic hemorrhages, that is a little bit more concerning. So you have your placenta. Now the placenta, it could start out really teeny tiny, right? It's going to start tiny. And then over time, it's going to get bigger and bigger and bigger. And the subchorionic hemorrhages, so if it's the point of my finger, at first, it might be huge. It might be taking up most of the placenta. But then over time, as the placenta gets bigger, even if it doesn't change, it's the same size. Now it's a little teeny tiny piece of that placenta. That's you also called a resolving subchorionic hemorrhage. But if you have multiple hemorrhages, right, all over, the concern is this placenta working well enough to support a pregnancy? So we do want to make sure we have a working placenta because that can be an issue. Now, going on to the first question. So that's the second question. Is it dangerous? I wouldn't necessarily call it dangerous for you, but it could be that it won't be a working placenta for the baby. But there's no way to know. Time is the only thing you can do. Now, when you have a person who's bleeding and the cervix was partially open, this is what's going on there. So remember, I told you this is our cervix and contractions start, and it starts trying to dilate the cervix, right? Well, for lack of a better way of putting it, your cervix is kind of like this at all times. And when it's opening, your tissue is kind of raw. So as the cervix kind of opens up, it's kind of, it bleeds. That's why when we see bleeding during an actual labor and delivery, a full-blown, we're ready to have a baby, whether it's preterm or full term, we see bleeding. And that's because it's the cervix which is dilating and the tissue is like getting raw and kind of tearing a little bit. So when you're having some bleeding at 27 weeks and the cervix is partially open, those two things make sense to me because the cervix partially dilated and that was where the bleeding came from. Do I think it's a subchorionic hemorrhage? Nope, because they would have seen it on the ultrasound. Anybody who's admitting to the hospital and who is bleeding, they're going to do an ultrasound to determine the cause. I have a video on what you can ask when you go to the hospital if you are going to get evaluated. But what I will tell you is the reason why I'm always telling you guys, if you're bleeding, call the doctor. If you're this, call the doctor. If you're that, call the doctor. They signed up to be 24/7, okay? And second to that, they need to assess you. And the number one assessment during pregnancy is an ultrasound. It's not perfect, as Lucine has figured out, but it's better than nothing. And it lets us look and see what possibly is going on. So do I think that's a subchorionic hemorrhage? I do not. Hi guys, I'm Dr. Samantha. Thank you for joining me. If you have any questions, please feel free to put them into the chat. For those of you who stay till the end, I will give you a sneak peek at next week's. All right, sorry, I keep saying that. At tomorrow's video. I have a video coming out tomorrow. Okay, going along with bleeding, I'm very worried. I am 17 weeks pregnant and I've been spotting for a week. My OBGYN said that everything it looks normal when I went there. Can you please resolve this? So, unfortunately, no. Believe it or not, despite all of our technology, despite all of our testing, there are women who will end up bleeding and they will bleed and we never figure out the cause. And a lot of people are very shocked when they hear that. But unfortunately, sometimes we just don't know. We don't see anything that's very obvious. And yet people will go on to have a very healthy baby and an otherwise uneventful pregnancy. The biggest thing to do when you're not sure why somebody's bleeding is to make sure that you're taking care of yourself to the best of your ability. So drink lots of fluids. Make sure some of those fluids are electrolytes. Try to eat healthy. Try to exercise. Sleep well. Stay off your feet, but not bed rest. Bed rest is not as good as people think. In fact, it's actually pretty bad for you. And you should only do bed rest if you've been told to do bed rest. So, you just try to get all of that stuff done to the best of your ability. But unfortunately, we don't always know the cause, and therefore we can't always solve the problem, which is very frustrating. I had a question on my STD, sexually transmitted disease video. So it says I'm 13 weeks pregnant and I got RPR positive for syphilis, but the confirmatory test is unknown. I currently don't know if I have syphilis. My question is, if I get treated for syphilis, will my baby be okay, or is there a risk? So syphilis is one of a couple different bacterial sexually transmitted diseases. It is unfortunately a very silent sexually transmitted disease. So oftentimes there are stages of syphilis where you may not have any symptoms. We always test all women for RPR in their blood. And we swab as well to make sure, because syphilis can lead the baby to have severe birth effects, including blindness. The treatment for syphilis is an antibiotic. It's very simple, very quick, and very effective. If you are RPR positive, you should get treated with antibiotics. Hands down, no questions asked, don't even pass go. The antibiotics that are used, they're not some crazy antibiotics. I think they oftentimes use penicillin, if I'm not mistaken. They may have changed it a little bit because there is starting to be some antibiotic resistant strains of syphilis, but I think it's penicillin. Penicillin's been used forever and a day. It's safe for your baby during pregnancy, and absolutely the benefits of being treated for syphilis far outweigh the risk. Because not only is there risk that the baby could have birth effects, there's also risk that you'll actually go into preterm labor or even have a miscarriage. So absolutely, you should get treated. I had a question on my yeast infection video, and it says, I have yeast issues in this pregnancy and have been on several over-the-counter and prescription creams. However, now I've noticed redness and pain around my urethra, and it burns when I pee. However, I don't have an STD, an STI, or a UTI. Is this a yeast infection or something else? Would Premarin cream help? I would not use Premarin cream during pregnancy unless you've been directed by your healthcare provider. Premarin is a medication that's like a hormone medication. It's used for a variety of different things, but it is definitely still hormonally based. You should not use anything that's hormonally based without being directed by your healthcare provider, because when you mess with your hormones, all these hormones that we've got going on during pregnancy are there for a reason, and there is a balance to them. And so if you are not balanced correctly, you might end up having an issue, right? So I'm going to tell you that I would definitely not use that without direction. So is this a yeast infection or something else? To be very honest, this sounds like it might be irritation from using a whole bunch of creams during your pregnancy for yeast. Our vaginas during pregnancy are very, very sensitive. A lot of the common causes of bleeding during the first trimester are related to sex. And that's because the tissue of the vagina gets very thin due to the hormones that are there for a safe pregnancy. And so those hormones allow the vaginal tissue to rip and tear a lot, which is just terrible, but it does happen. And so that redness and irritation sounds like that actually might be what's going on. There are oral medications that you can take for yeast infections during a pregnancy. Diflucan gets a really bad rap because if you take it at high doses, it is definitely hazardous, but at low doses, it is often used. I would tell you that I also think you should be asking to speak with an infectious disease doctor or a urogynecologist who treats pregnant women. So urogynecologist, urology, gynecologist, so GYN, so women's stuff, right? So a urogynecologist is familiar with women's urinary issues as well as like the gynecology area. That might be the doctor that could really help understand what's going on and maybe help direct the care, maybe in conjunction with your OBGYN. So that is what I would do for that. If you guys have any questions, please feel free to put them into the chat. I got a question on my high blood pressure video. So it says, I have hypertension and I'm trying to conceive. I have been using Nicardia retard. That's what was written. 10 milligrams for the last 15 days. My blood pressure is normal now, but I have severe headaches. What can I do? Can I use amlodipine instead of Nicardia? Amlodipine doesn't have any side effects for me. So one of the things you guys need to know is when we're educating as a healthcare provider, when we're educating on these medications, we have access to a whole bunch of different resources. And these resources come from evidence-based information from a variety of sources on the safety and efficacy of medications. So amlodipine is not usually used. And I'm just looking to see if there's... Yeah, so amlodipine is not usually used. It's not a preferred medication because amlodipine is actually linked to preterm labor, amongst other things. So we don't try to use it. It can be used if nothing else is available. Now, I am not familiar with the name Nicardia. So that is not a medication that is used where I am at in the United States. There's a couple of different medications that it could be, but since I don't know for sure, I can't comment on it specifically. What I can tell you is that you want to ask for a pre-conception, that's before pregnancy, consult with a maternal fetal medicine physician. Again, high-risk doctors. They're the ones that are going to take care of you if you have high blood pressure during your pregnancy. You can ask to meet with somebody pre-conception to talk about the right medication for your pregnancy. Beta blockers are consistently used during pregnancy, like metoprolol and propranolol. So this is one of the medications that you could potentially ask for. So what I would tell you is you really need to go ahead and you need to ask to speak with a maternal fetal medicine ahead of time. Now, the other place you guys can go if you're worried about the medication that you've been prescribed and the conversation that you're having and whether you've been given all the information you need is your local pharmacist. Pharmacists also receive specialized training in medication, and this is something that they can also guide you with. What I will tell you is if you're of childbearing age and you're considering getting pregnant or you're not on birth control, you need to have an active conversation with your healthcare provider. I get women coming to me all the time that are about to get pregnant or are pregnant and they're on medications that they shouldn't be on. And I have to work on getting them off of them as fast as I can because the medications are not safe for pregnancy. And so it's really important. A lot of these women, when they figure that out, they're very frustrated because they wish somebody had talked to them about the safety and efficacy of their medications and what the ramifications would be if they got pregnant. So, I would tell you, if you're about to get pregnant, please feel free to have that dialogue with your provider. That's what they're there for. I'm high-risk patient with high blood pressure, 4th pregnancy. I was wondering if I might be able to request having a C-section instead of a vaginal birth. I'm 31 weeks and 40. I'm assuming that's your age. So you can request a C-section. They are still not going to C-section you before 39 weeks. I would ask why, because there's a lot of risks associated with having a C-section. And a lot of the times a vaginal birth is actually better for you from a blood pressure standpoint. So one of the things that affects our blood pressure and makes it go both high and low is blood, our blood volume. You'll have a higher risk of losing more blood during a C-section. So it doesn't necessarily, a C-section doesn't necessarily reduce some of the risks. However, if you're worried about a lengthy delivery process, I would consider getting an epidural and seeing if they can induce you. And if even after like 8 hours or something, if it's not working, then just go do your C-section. You need the epidural anyway in place for a C-section. So let me know in the comments, like what your thought process is as to why you would prefer a C-section. Now, women do request C-sections. That is a real thing. Your doctor is obligated to give you the risks and the benefits no matter what, even if you are very adamant that that's what you want. That's their job. But you are allowed to request that and have that dialogue. My umbilical cord is also dilated. We're going weekly to have NSTs on my baby to monitor that. Okay, so that's a better reason, potentially, not to say your other reason wasn't valid, to go ahead and have a C-section. So the umbilical cord for her baby. So you have the placenta, and attached from the placenta is the umbilical cord that goes to the baby's belly button. That's like how the baby is fed. And when you have an umbilical cord that's not quite working right, there's increased risk for the baby to reduce fetal distress. That's what she just said. So when it comes to the baby, a C-section is less fetal distress. 1,000%. Well, I say that. I shouldn't say 1,000%. I should say like maybe 95% of the time. With a C-section, the baby doesn't have to go through an active labor process. So the baby doesn't have to go through contractions and all that stuff. So what happens with contractions, and I have a video on fetal heart rate. So many people come into the hospital and they just stare at the baby's heart rate. And I actually have a video on NSTs, but that's a non-stress test. So what this is looking for is we put a mom on a monitor and we're checking to see a whole bunch of different factors, one of them being the heart rate. And one of the things we're looking for is the pattern of the variability. A baby's heart rate should not be flat. That is bad. We want a baby to bounce around. But there's a pattern to it that we learn as healthcare providers. I actually have my advanced fetal monitoring certificate through A1. And so I had to learn, just like a lot of your labor and delivery nurses learn, what all that means. Now, when the baby is going through labor, there are pieces of time where the baby's heart rate will drop. And those drops are normal drops, okay? Those drops happen because of head compression. So the contractions push the baby's head down against the cervix, which helps to dilate it, and the baby gets a little bit of a heart drop. But there are other types of decelerations that we see that are more indicative of fetal distress and have to do with oxygenation and possibly fetal blood flow. And so what Bologna is saying, sorry, I hope that's, that's what you wrote, right? So what Bologna and Cheese is saying is that her concern is that with this abnormal umbilical cord with possibly a change in the blood flow, this is potentially going to put the baby in distress faster. So with this kind of thing and high blood pressure, 100%, I'd be asking for them to really consider it. So the other thing you guys need to know about high blood pressure, what happens with high blood pressure is as your blood pressure is high, the placenta gets used to a higher pressure to push the blood through to the baby. So as the pregnancy progresses, we actually can't drop the blood pressure too low. So if a mom comes to us with, say, blood pressures in the 160s over 110s, we don't actually drop her to 120. That would actually be really bad for the baby, because by the time you're coming to us at 160, our goal is to keep your blood pressure high enough to allow the placenta to function and low enough to prevent you from getting preeclamptic. So we actually have to balance all of that. And so one of the things that happens with all of this as well is that with a higher blood pressure going through that umbilical cord, it is possible that that's going to be a bigger issue for the baby. So yeah, no, in that case, for sure, you're going to have a lot better idea. I want to get fixed as well. Yep. My last baby went into fetal distress and I almost had to have an emergency C-section. So yeah, that was probably really, she had an emergency C-section because the baby had distress. That is extremely stressful. And if your babies were on the larger size, then this baby's probably going to be even larger if you go to full term. Absolutely. Here's the other nice thing. Just so you guys know, I think C-sections are brilliant. Now, I've never had a C-section. Don't claim. Oh yeah, 8 pounds, 8 ounces. You probably were in distress because he was so big. And if this one's as big, yes, I would just, yes. So I've taken care of so many women who've had C-sections, and C-sections are brilliant in many ways. So yes, it is major abdominal surgery. Do not get me wrong. Bologna and cheese is major abdominal surgery. Okay. You do need help, but they give you good drugs, and those drugs are good for breastfeeding. Okay. So take the meds. Those meds are there for a reason. You need your village. You definitely need help because it is harder, especially if you're going to have an 8-pound baby, but you get your guaranteed delivery date, because guess what? They schedule it for you like 6 weeks in advance. So you can have everybody can fly in. Everybody knows what's going on. We cross T's, we dot I's. Unless you go into preterm birth, you know when everything is going to happen. You have your pick usually of a day. So if you are going to have a planned C-section, request a Tuesday, guys. Tuesday is your magic day to have a baby who is a planned C-section. Tuesdays are the day that everybody's already come back from the weekend and they realize that they are in a Monday through Friday job. All the managers, all the assistant managers, all the directors, all of the departments, everybody you need is already there. You have a planned C-section, so they have a bed for you. All the lactation consultants are there. Everybody is fresh-eyed and ready to go. So you really get the best of all the staff as well. So get a Tuesday C-section and that might work out for you. Morning, Sapetti. How will you know if your baby is a boy or a girl? I get this question a lot. If you get an ultrasound and or the blood test. And honestly, the ultrasound, even today, guys, is not always accurate. I have been in the room where we delivered a baby and it was not the sex the ultrasound said. And I have seen that, and I've seen where the ultrasound said it was a boy and it was a girl, and where the ultrasound said it was a girl and it was a boy. So that can actually happen. The blood test now that they do can actually test to see what chromosomes your baby has, whether it's an XX or an XY, to tell you if it's a boy or a girl. So what a lot of people don't realize, and it's starting to explain stuff like the RH incompatibility and stuff like that, is that your baby's blood actually circulates into your blood. So we can actually draw out blood and we'll pull out your baby's DNA from your own blood. And so that's how we're able to identify the baby's blood and chromosome and check for genetic diseases and genetic disorders. So that's actually something that's how we do it. This is also why our immune system, for example, a lot of people don't realize this, but when you're a pregnant woman, you're immunocompromised. So when they're telling you not to eat like the raw cheeses and the raw fish and all that other stuff, the reason why you'll sometimes see like, oh, don't eat sushi, but it's okay sometimes, is because it's not necessarily that sushi is bad, right? Or it's not necessary that some of those unpasteurized foods and stuff are bad, right? If they were bad, nobody would eat them ever. But you are immunocompromised. As a pregnant person, your immune system has to go down. It has to calm itself down and kind of go dormant because it can sense your baby's genetic material in your bloodstream. And when it sees that, that is a foreign body. That is not your blood. That is your baby's blood. And your baby is the result of you and your partner. And so, or you and your donor, if you're an IVF, right? And so that genetic material together is different than yours. So if your immune system was at full-blown max capacity, it would be attacking the baby. And that's what we see sometimes with RH incompatibility. So the reason why there's a lot of advocacy for pregnant women to get the flu vaccine, to get the COVID vaccine, and stuff like that, the dietary restrictions has to do with your immune system being compromised and us trying to protect you. It's like almost as if you are a cancer patient, to be very honest. And so we need to be careful. I hope that answered your question, Sapeti. I know it's a very kind of boring answer, but really it's just ultrasound or blood test. There's nothing, none of the anecdotes that you'll hear is none of it's ever accurate. So the last thing I had was a kind of another question on anxiety, and it said, I'm 28 years old. I'm pregnant with my first baby. I'm scared because I have high anxiety. I always feel palpitations and worry. How could I overcome this? Because of my anxiety, my blood pressure rises every time I have a check. So blood pressure rising every time you have a check is called white coat syndrome. It's a real thing. It's anxiety when you go to the doctor, and it oftentimes results in high blood pressure, high heart rate, all this different stuff. And it's very common, and we're kind of used to it. And a lot of people get really scared and stressed out at the doctor's office. And so we see it. Now, the thing is that one of the things I try to get my patients to figure out, and I think that's very important if you guys are having any anxiety, is your anxiety physical or emotional? So a lot of people have never thought about anxiety in this way. So we hear about panic attacks, right? So panic attacks, generally speaking, are where somebody will describe their chest tightens, they get a high heart rate, they may breathe a little bit faster, they may get sweaty, they may get dizzy, they may get nauseous, and this is associated with anxiety. They're feeling anxious over something, okay? But you heard those are all very physical symptoms. Now, if you've ever had that kind of physical reaction to a trigger, and a great example would be what my family calls a jump scare. So a jump scare, you go into a haunted house and all of a sudden somebody pops around the corner and goes, boo. And you get that, that's a jump scare, right? So with a jump scare, you get that kind of feeling, right? And then your heart will kind of race and your chest tightens. That's a very similar feeling to somebody who has a panic attack. But with my jump scare example, I have a cause and the effect is this panicky type of feeling. Once you've had that a couple times, if you feel your heart start to race, you may actually induce anxiety and a panic attack where there was no anxiety to begin with. So this means I'm sitting on my couch, I'm doing nothing, everything is cool, life is good. And all of a sudden my heart starts to race. Now nothing was going on, but my heart starts to race and I get nervous and then I'm anxious. That is a physical anxiety response that I'm like saying to you, try to identify. Second scenario, I'm sitting on my couch and I'm worried about my mom who is in the hospital because she's having a surgery. And then my heart starts to race. That is an emotional first response. Okay. The reason why it's important to identify the two is what I found in my practice is a lot of times the anxiety that's actually physical in nature first is a lot of times related to dehydration and lack of electrolytes. So I would tell you, if you are sitting back thinking about your anxiety and when you get palpitations and when you get this other stuff, are you drinking enough? Is it physical first? Because when your blood pressure is low, because you're like dehydrated or something like that, your heart starts to race, right? Because it's trying to pump your blood around, and then you can actually end up with a rebound high blood pressure. And so this is why it's important to kind of identify the two. So, if anybody has any questions, please put them into the chat. My name is Dr. Samantha. I am the maternity mentor. I'm here every Monday at 9 p.m. Eastern Standard Time to answer your questions. I am also on Facebook and Instagram, so you can check me out over there. Please like and subscribe to the channel. Please subscribe to the channel. Please share it with your friends and family, but please subscribe. Subscribing to the channel is very important for content creators. YouTube wants to know that we have subscribers, we're growing and building, and so it really helps me out. And because so many of you have subscribed and so many more continue to, I am now a part of the YouTube health platform. So this is an area of YouTube where YouTube has taken the time to vet providers. I had to provide my education and my licensure so that they knew I was actually a real licensed provider with a real education. They verified my content, and now I'm a certified, like, as part of the YouTube health platform. So you know you're talking to somebody who is a real healthcare provider. Please keep subscribing. I appreciate all of you. I appreciate everything you do. For those of you who stuck around until the end, I had multiple viewers ask for this video. So tomorrow, not next week, tomorrow, I am coming out with a video on European baby formula versus United States or US baby formula. All the differences, everything you need to know, and what you can think about it. So please check it out tomorrow. Subscribe, hit the notification bell, and you'll be notified when it gets posted. I appreciate you all. Thank you for being here on a Monday night. My name is Dr. Samantha. I'm the maternity mentor. Bye for now.